Hello, dear friends. Today we are talking about two syndromes, dysphagia and gastrointestinal bleeding. The word dysphagia is derived from the Greek phagia to eat and dys with difficulty. It refers to the sensation of food being obstructed in the food passage anywhere from the mouth to the stomach. The basic impairment behind dysphagia are neurological or mechanical obstructive. The act of swallowing requires a passage for food and drink from the mouth into the stomach. From mouth to hypopharynx covers 1/3 of passage distance, while 2/3 is covered by the esophagus. The swallowing center in brainstem is located into the floor of the fourth ventricle and adjacent region of medulla. From here, it's connected to the cerebral cortex, vomiting, and respiratory center. All these areas works in coordinated manner to provide voluntary as well the involuntary control of swallowing. An adult swallows approximately 580 times daily, and the act goes in unconsciously. Swallowing phase, there are two types, two phases: oropharyngeal phase or voluntary phase, and esophageal phase or involuntary phase. Food bolus is propelled through the esophagus by an involuntary wave or contraction mediated by the enteric nervous system. The primary peristaltic contraction, which is initiated by a swallowing, moves down the esophagus at the rate of 2 to 4 centimeters per second and reaches the distal esophagus about 9 seconds. This duration varies from 8 to 20 seconds. Clinically, dysphagia presented by pain and difficulty in swallowing, sensation of food being stuck into throat or chest, coughing or gagging while swallowing, or nasal regurgitation or dysarthrias or nasal speech because of associated muscle weaknesses, or frequent burning sensation in chest, and having food or stomach acid back up into the throat, and unexpectedly losing weight. There are 6 grades of dysphagia. First grade is when your patient has complaints of dysphagia but still eating normally. Second grade is characterized by requires liquid with meals. Third grade, able to take semi-solid but unable to take any solids. Fourth grade is able to swallow liquids only. Fifth grade, unable to swallow liquid but able to swallow saliva. And sixth grade, it's extremely dysphagia, unable to swallow even saliva. Because of etiology, dysphagia has been classified broadly into two types, this oropharyngeal and esophageal dysphagia. Etiology factors for first oropharyngeal type. On the first place, neuromuscular diseases, which contains the central nervous system disorders like cerebral vascular accidents involving the brainstem, Parkinson's disease, Wilson disease, multiple sclerosis or brainstem tumors, or damaging of peripheral nervous system, poliomyelitis, peripheral neuropathies, or damaging of motor, for example, myasthenia gravis, or damaging of muscles, or oculopharyngeal muscular dystrophies, primary myositis, and any metabolic myopathies. Next is mechanical or obstructive lesions because of inflammatory, for example, pharyngitis or abscesses or tuberculosis, and because of neoplasias or Plummer-Vinson syndrome, or extrinsic compression because of compression from increase enlarged organs like thyromegaly or cervical osteophytes, or any lymph enlargement like in lymphadenopathies. Disorders of the upper esophageal sphincters is related to the abnormal upper esophageal sphincter relaxation or opening. It may be because of incomplete relaxation, for example, echalagia, cricopharyngeal echalagia. For what does it mean? It's no echalagia, and echalagia is relaxation, no relaxation, or inadequate opening, cricopharyngeal Zenker diverticulum, for example, you see here in picture, and because of delayed relaxation in familial dysautonomias. Next is esophageal dysphagia's etiology factor. On the first place is neuromuscular disorders, most common achalasia, diffuse esophageal spasm, or other motility abnormalities. For example, in motility disorders may develop because of secondary reasons, scleroderma, collagen disorders, Chagas disease, and etc. Next is mechanical or obstructive reasons in esophagitis, which develop in esophagitis, or dysphagia is due to mucosal edema or benign stricture, gastroesophageal reflux diseases, and infectious esophagitis, or because of medication-induced esophagitis, or radiation treatment, or disorders of wool, for example, esophageal stricture, or Zenker diverticulum, or epiphrenic diverticulum. So on the last page you see epiphrenic diverticulum, or sorry, Zenker diverticulum. Here you see gastroesophageal reflux disease, and the first place you see esophagitis. Next, also reasons of esophageal dysphagia is disease causing external compression, like hiatus hernia or cervical osteophytes, or vascular ring dysphagia lusoria. You see here, this is additional brachial artery developing, which can also compressed from outside esophagus, and luminal obstruction, foreign bodies, esophageal webs, Schatzky rings, and carcinoma esophagus. There are associated symptoms and possible etiologies. For example, if your patient has difficulty in initiating swallow, it most likely reason is oropharyngeal dysphagia. For example, your patient has food stick after swallowing in chest, it's maybe because of esophageal dysphagia. Progressive dysphagia may caused by neuromuscular dysphagias or carcinomas. Sudden dysphagia, most likely it's foreign bodies, or sometimes esophagitis. For example, if your patient has weight loss in elder patient, it's mostly caused by carcinoma, or if your patient is has also with weight loss regurgitation, it's because may develop because of echalagias. Dysphagia related to solid food only is obstructive dysphagia, solid and liquid both. It's maybe may caused by neuromuscular dysphagia. Diagnosis of dysphagia, of course, you should very closely provide interview. You should get a very correct history of disease. Of course, this is clinical examination, blood investigation. This is hemoglobin, total count, and differential count, serum iron. For example, dysphagia may develop because of very severe iron deficiency anemia. Radiology, this plain X-ray, barium meal, and upper GI endoscopy, laryngoscopy, manometry, 24 hours pH monitoring, endoscopic ultrasound, and of course histopathology. For example, plain X-ray neck and chest we use for diagnosis of foreign bodies. You see, barium swallow, for example, you see here picture at mid-esophageal diverticulum diagnosis by barium swallow, epiphrenic diverticulum, or Zenker diverticulum also may diagnosed by barium swallow method, and echalalia or sigmoid esophagus echalalia, or sometimes it's maybe defects of filling of barium. This may be caused by carcinoma of esophagus. Of course, we use kind radiography. This is dynamic assessment, radiographic visualization of food bolus movement from oral cavity to hypopharynx. Endoscopy method. We can use because of two reasons: for diagnostic reason and therapeutic reason. For, of course, we use endoscopic method for visualization and also taking biopsy materials. And second place, we can use to provide the therapeutic procedures like foreign bodies removal or stenting or dilation. You see here also endoscopic visualization, Barrett's esophagus, for Schatzky ring, esophageal diverticulums, or esophagitis. Also, next method is manometry. Manometry, when you're assessing the pressure inside of esophagus, and 24 hours ambulatory pH monitoring, most direct method of measuring increased reflex is by an indwelling pH electrode, or more recently via radio telemetric pH monitoring capsule that can be clipped to the esophageal mucosa. And also very important method, endoscopic ultrasound. We provide rare than endoscopy, but sometimes it takes place when you are scanning the tumors of esophagus. And of course, histology method, investigation of biopsy materials. Next topic is gastrointestinal bleeding, and this describes every form of hemorrhages in the GIT from the pharynx to the rectum. Can be divided into two clinical syndromes: upper GI bleeding, what does it mean, upper pharynx to ligament of trace, and lower GI bleeding, from ligament to trace to or from ligament of trace to rectum. Upper GI bleeding remains a major medical problem. About 75% of patients presenting to the emergency room with GI bleeding have an upper source. In hospital, mortality of 5% can be expected. The most common causes are peptic ulcer, erosions, Mallory Weiss disease, and esophageal varices. Clinically appear by hematemesis, melena, coffee ground vomiting, and hematochezia. Hematemesis is vomiting of blood, whether fresh and red or digested and black. Melena, passage of loose black terry stool with a characteristic foul smell. And coffee ground vomiting, blood clot in the vomiting. And hematochezia is passage of bright red blood per rectum if the hemorrhages is severe. And there are etiological factors. We have mostly esophageal bleeding caused by esophageal varices, for example, which may develop because of liver cirrhosis, increasing pressure in portal vein, and enlarging of esophageal veins, esophageal carcinoma, or reflux esophagitis, or Mallory-Weiss syndrome. Stomach bleeding may caused because of gastric ulcer, erosive gastritis, and also tumors, and etc. And duodenum bleeding may because of duodenal ulceration or duodenitis, and aortoduodenal fistulas, and etc., and also tumor. And general etiological factors connected with blood disorders like hemophilias, leukemia, thrombocytopenias, and prolonged time anticoagulant therapy. To investigation, we use full blood count, of course, hemoglobin level, white blood cells level, liver function test when we have suspect cirrhosis, liver cirrhosis, and coagulation profile, renal profile, RBC morphology, and imaging methods, endoscopy, ultrasound, and CT scan. Lower gastrointestinal bleeding, lower GI bleeding may caused by bleeding from small intestine, colon, and anus. Small intestine bleeding causes there are Crohn's disease, diverticular disease, or benign or malignant neoplasms, and from colon is carcinoma of colon, polyps, and diverticulars, or inflammation maybe, angiodysplasias, and from anus, of course, this is rectal carcinoma and polyps, and sometimes as hemorrhoids and anal carcinoma. History taking, it's very important to to suspect the diagnosis and to prove the diagnosis. For example, blood its own or streaking the stool. It's caused by from rectum, polyps or carcinoma or prolapse, and from anus is maybe caused by hemorrhoids, fissure in anal carcinomas. If your patient has stool mixed with blood, it's mostly caused by GIT above sigmoid colon or sigmoid carcinoma or diverticular disease. If blood separated from the stool follows defecation, this is because of anal condition, hemorrhoids, blood is passed by itself. It's a rapidly bleeding carcinoma or inflammatory bowel disease, diverticulitis, or passed down from high up the gut. And blood is on the surface of the stool, suggests a lesion such as a polyp or carcinoma further proximally, either in the rectum or descending colon. If blood on the toilet paper, fissure in ano, or hemorrhoids, loose, black, tarry, foul-smelling stool, or meliana, from the proximal of flexure. Investigation, of course, full blood count, coagulation profile, helical CT scan, colonoscopy, and proctosigmoidoscopy, esophageal duodenoscopy to exclude the upper GI bleeding, and of course, sometimes, for example, in colon, a double contrast barium enema. Thank you for your attention.